So we're going to talk to you about wound care in venous disease. So obviously you saw the differential is pretty broad. You can come across many things. And we have wound care specialists. We have referral from wound care, but many times we are that first step that our referring physicians count on to evaluate these patients. As we know, venous ulcers are extremely common. Because venous disease is the most common vascular disorder. So what do I do? How do I manage these patients that come to me with an ulcer that may be venous? Well, first of all, diagnose whether it's related to venous disease, go through the differential. If I feel it is venous disease, make a plan of care for their venous disease, and start trying to manage that wound. As we may already know from experience, these wounds tend to heal pretty quickly. I had a picture of a initial slide did not carry, but it showed some fishermen in the famous wall in Cuba, Malecon, just fishing. They all have rods with them. They're all fishing. They're all fishing for the same fish, and they all start with long rods going right off into the water. So we all start with a very common path. However, that filament that they're using might be different from one to the other. The hook might look different, and the bait is definitely likely very different. That's really what wound care is about. There's a lot of choices out there. It's very driven by the industry, much like venous disease has been, and it is an evolving field constantly. What works for arterial wounds, neuropathic wounds, skin wounds is not necessarily what's going to work for venous wounds. And what really works for venous wounds is treating the venous disease. The quicker you get to treating that venous disease, the better you're going to be. But start with the physical exam, your clinical history and examination of that leg, okay? The vascular assessment is key. As vascular specialists, we want to make sure it is venous, or is it arterial, or is it other, or is it a mixed ulcer? So make sure that you take that into consideration. If it's looking different, strangely, it's not fitting into that venous arterial component, think of biopsy. Could it be a malignancy, as Dr. Deal already spoke of? And obviously the imaging is critical for us. Sonography is a must, whether then we switch to our CTV, NMRV, IVUS to confirm suprainguinal disease is key. The identification documentation, not going to be redundant, but we know what classic venous ulcers look like, that just as Dr. Deal touched briefly, but the location, the irregular flat, only slightly steep borders, they are very painful, and as well as the history. But don't forget the atypical, okay? Here's two non-medial extensive ulcer that was 100% venous, and it healed very rapidly after management of the venous disease. The other one is a gentleman with squamous cell carcinoma that had radiation therapy and ended up with what's considered a radiation ulcer. But he also had concomitant venous disease that had been ignored for 2 years. Hyperbarics, multiple wound cares did not help this gentleman. So making sure that if it's, you see venous disease, your physical exam, it might not necessarily fit the classic, but treat the venous disease. That tissue tells the story, okay? So look at the tissue, document what you're seeing. This is critical. One of the things that is key throughout your encounter with this patient is documentation of that ulcer, what it looks like, size, and obviously management. So black, necrotic, yellow, slothy, red, granulating, pink, epithelializing, and green, usually infected. That's Pseudomonas. That's the capital in Cuba, Havana, Cuba, built after the model of our capital. I find it quite amazing. The roof is in gold, donated by the Russians, kind of quite a contrast of all these mixed things coming. It's a beautiful structure amongst a lot of very destroyed buildings. Basic general management of wounds, elevate them, elevate that leg, okay? Nice evidence to suggest that 30 minutes to 3 to 4 times a day improves. Not everybody can do that, we know that. Encourage exercise, control the other controllable risk factors, the obesity, the smoking, the diabetic control, which is much of a nutritional optimization okay? We might see some healthy patients come through our door. In our Western society, we all pretty well nourished, but we do get the elderly, and these patients might not be properly up to date in their nutrition. So do consider their lack of protein. Yesterday, you saw in brief slides a Juban. It's just a nice collagen peptide with some evidence. Juban is expensive, not always covered. Collagen peptide is collagen peptide. It is cheap in Amazon. So think outside the box. It's just basic nutrition. In key vitamins that are involved in wound healing, A, C, and zinc, nothing that a multivitamin cannot fix. So if you're dealing with that elderly, frail patient, think of their nutrition. Think about the whole patient, not just the vascular. We can make a big difference in these patients. Skin cleansing, this is not rocket science, okay? Simple skin cleansing with tap water, it's been shown to be no different than any of these sterile solutions out there. The surrounding stasis dermatitis and control of this is key. These patients have a lot of inflammation. Think of it as your third-degree burn. The surrounding tissue is second degree, and the further surrounding tissue to that is first-degree burn. So you have to take care of everything around the wound. These patients may have a lot of irritation, itching. So you want to make sure that skin is healthy, moisturized. And there are a lot of emollients out there, kind of like Epi serum that I use very frequently in gut feedback. For further irritation, trying to avoid some of the dermatitis itching, a mild to moderate steroid such as triamcinolone 0.1%. Compression is key. I'm not going to beat this. Ms. Morrison did a great job at compression. There's a lot of diversity out there. The elastics, the inelastics, the compression stockings, the different types, and the sequential pneumatic pumps. So here's a list of what obviously your graduated compression stockings can be and how to think about them. Just become familiarized with your choices and what your patient can tolerate. Pharmacology is key. As you were all should be familiar with, venotonics have really exploded, and now some carriers payers are demanding that the patient has trial of venotonics even when they don't have an ulcer. So guess what? I put my patients with an ulcer on this venotonics, the most common, a purified fractional diosmin, Vasculera, or vein formula, or whatever your choice is. As long as your patient is using it and taking it, it's better than nothing. Then there's obviously the rheologics that decrease blood viscosity, allow for improved flow properties. The classics, pentoxylphenol, I can say that well. It's been 10 years trying. I'm not going to accomplish it after a decade, unfortunately. A lot of, it works well, good evidence behind it. A side effect is primarily nausea, and that's what I've encountered with these patients. Also, you got to take it 3 times a day. So who's going to be more compliant 3 times a day with some GI effects, or somebody taking Vasculera once a day or vein formula once a day? Pain management, don't forget, just basic pain management as well as your neuropathic pain management. These patients may have some residual pain. You do not want to ignore that. Infection, this is something that I get a lot of questions about. And I was just discussing yesterday with one of our colleagues, do I culture all of this? Don't. There's no evidence that you need to culture every one of these. They're all colonized. You're going to get a mixed flora, okay? And if it looks infected, treat it at that point. Don't think that putting these patients in antibiotics ahead of time is going to make some better wound healing. But if you're getting systemic signs of infection, focal signs of infection, please get started with the antibiotics. Be broad, and then do culture it. Atypical infections continue. Antimicrobial antiseptics, same idea. Debridement is key. We can get started with some simple wet to dry debridement in the office. Consider some chemical, obviously mechanical surgical debridement you would send out. The choice of dressing, I'm going to be key here. There's no single dressing material that is shown a favorable one over the other. This is very industry driven. Make sure that it's cost effective, accessible, and the patient can do it. That's it. Additional agents, collagen works really well. It can be cheap. It is covered. Colony stimulating growth factors, they are expensive and painful. Silver compounds, I don't like these silver sulfidine. It's messy. It has sulfa, but I do like some of these silver gels available. And honey has not been shown, at least in the venous ulcers, to be of any benefit. And finally, consider referral for wound care specialists, okay, especially when the wound area is large. You have a obese patient, they have limited activity, other comorbidities. The ulcer is deep or atypical, as discussed, is resistant to treatment, or recurrent infections are occurring. You are uncertain about the diagnosis, and if the wound is not responding, if you felt that it was venous and you treated the veins, is not responding to the treatment. Thank you so much.